Oncology, Sri Shankara Cancer Hospital, with more than 40 years of experience and surgical expertise in head and neck surgery. His profession in laryngeal surgery. We welcome you, sir, as a panelist.
At the outset, I would like to thank Dr. Srinath, Dr. Karthik Rao, and others for having given me this opportunity to share this session. Of course, we are talking about the complications, routine complications of the head and neck surgical procedure, especially the oral cavity, larynx and neck dissection and reconstruction. And you all know, of course, in the early 30-40 years back, the head and neck surgery means surgery followed by adjuvant modality of treatment. Now, of late, second and third decade, there is a paradigm shift in the, as Dr. Sultan Pradhan told today morning, there is a paradigm shift of the management of these tumors. With the idea of organ preservation, more and more, especially after veteran RTOG study, more and more chemoradiotherapy are used with the idea of preserving the organs, and more surgeons are forced to do a salvage surgical procedures without reconstructions. And we are bound to face a lot of complications. Of course, initial assessment of these patients, the probable complications and detailed counseling with the patient attendants is a paramount importance, and the hospital's stay, cosmetic results, complications, all these things is better to counsel with the patient attendants regarding these complications. With this, I would like to ask Dr. Karthik Rao to take over.
Thank you very much, sir. I'm actually very much excited. I feel like my role has reversed. Like, I was the person who was being asked question during Viva and all. Now it is my job to ask the question to the people who used to ask me questions. So let's test their knowledge. I know, obviously, they will excel in flying colors. So, sir, actually, I have kept the panel cases very simple. These are the cases which we will routinely encounter in life. So these are the cases which day in and day out we come across. And there are a few cases where it is complex and we may encounter it at a rare setting. So I would want panel's opinion. Dr. Cesare, I hope you are able to hear the talk. Yeah.
Yep.
Yeah. Okay. So let us start the panel discussion. So starting with first case. Is it this? Yeah. No, it's not working.
Okay.
Okay, we'll start with a few neck dissection scenarios and then we'll work around it and then go on to the scenarios for laryngectomy. This is not a movie, so I would request everyone to stay awake. Put one light on at least. Yeah. Yeah. I am not the spotlight. Spotlight is there. Put the spotlight over there. Yeah, great. Thank you. Okay. So to start off, we have a 42-year-old male, good performance status, who had a carcinoma of right lateral border of tongue. So the patient has undergone right tongue wide local excision, selective neck dissection 1 to 4, and primary closure. So the on-call resident calls you at 12:30 a.m. in the night, tells you, sir, drains are not holding. So, sir, KK sir, the question is for you. What are the most common issues for drains not holding?
First of all, you should say, at least tell your residents not to call at 12 midnight about the drains.
They are very sincere. They are very sincere and they care about patients.
And they try to get back at KK because he's been troubling.
Sir, also they want to show that they are working at 12:30 in the morning.
All right. So the drains not holding, the primary problem is there is somewhere leak is happening.
Right.
the system is not working.
Right.
It can be at multiple places.
Right.
First of all, the closure should be fine, airtight, and it has to be checked before the patient is out of the table. Second thing, the system, the box may be defective sometimes. That has to be checked. And sometimes if it is a Romovac drain, there is a lock in the middle. There is a small cap-like thing, and one of them may be kept open. So I think at resident MCS level or even MS level, I think they should be have that knowledge to check all this and settle the things then and there.
Yes.
So they call me.
Right. I agree with you, sir, but unfortunately we don't have MCH everywhere, so we have to work around with other this thing. So as rightly mentioned, so we need to assess where the site of the problem is. So it could be because of the drain tubing holes being outside the skin and the peri-drain stitch not being taken well. So sir, Pfizer wants to add it.
And also when you said wide excision,
Right.
is it anterior
I'm
or
coming to
posterior?
it, sir. I'll come to the scenario. I knew you would come to it, so whatever. Yes, sir.
One more point, drain may not work.
Yes, sir.
If there is an oral cavity communicating.
Yes, sir. I'm coming to that as next point. Next point I would be coming. Any other point which panelist wants to add? I think this is a simple scenario which I wanted everyone to be sure that where the problem is, we need to understand. We need to be sure that we should know how to place a drain, and a surgeon who is operating must ensure that intraoperatively the drains are holding. So what would you think in this case, like, in a tongue wide excision? I have worked at some centers, but I have seen drain being placed at various sites. So some place under the mastoid, despite of them taking a horizontal crease incision for the neck dissection. I have seen them place well in the neck. What do you think is the right place to place the drain, sir? Krishnappa, sir.
What we have learned with Manjula sir and all, retroauricular. So it will go with the muscle piercing, it will comes out. So there is very minimal of ear leak or something like that, ooze alongside of the tube into this. So it will be airtight, will be there, and you can fix the one in the segmental area. We do not put a stitch around the tube, so we fix it as sir said. One in the lower at the level 5. We do.
Yes, sir. Dr. Cesare, do you have any other points in mind to come up with?
Well, I always stress my residents to put the drainage always in the more inferior part of the wound and to put it into the surgical cavity, not superficial to the muscle, but within, for example, in a case of neck dissection, around the sternocleidomastoid muscle up to the level 2A or 2B, and obviously to make a very airtight closure and to fix the distal part of the drain very well to the skin. Yes, usually these are my caveats.
So you want to add something?
Yeah, so we are placing a drain to drain a dead space. So if you are done a full neck dissection, there are two dead spaces, one in the submandibular region and one in the supraclavicular region. So you need to drain these two areas. Where you exit the drain is within your fields of radiation. So if you're going to give radiation to this patient, you cannot be placing a drain too far away. In that port also, that site will also be covered with your radiation field.
Yes.
So do not actually increase the fields of radiation. If you place a nice horizontal incision, it's better to just place a drain just alongside that. So you can place it beneath the muscle, as Professor Piazza said. Your drain has to be under the sternomastoid and it has to exit, taking care that you don't damage the external jugular vein, the spinal accessory nerve, and it has to exit at the skin just 1 centimeter away from your incision.
As rightly mentioned by sir, so the drain site is also considered as a site for primary, and it will receive the same dose of radiation what the site of primary would be receiving. So sir, in this case we were discussing about tongue wide excision. What if this case was of a total laryngectomy where we had done a total laryngectomy followed by bilateral neck dissection, and drains are not holding. Shiva sir, would you want to take this question? So why would the drain not hold in a patient who has undergone total laryngectomy?
So again, apart from the reasons already mentioned, the other thing in a total laryngectomy is when you form the stoma is not giving you the airtight seal. There's a leak around the stoma. So that is why I still remember what I learned from Nanjundappa sir is that when you're making the tri-pointer at the junction of the mucosa and the cartilage, that is the site where it often leaks. So you have to take sure that at these 2 points you need to take the sutures properly to achieve the seal. Otherwise, and also what happens is you tend to place the drain just above that stoma there. And if you don't take proper care of this, it's going to leak. And in total laryngectomy is even more important that your drain works. And because your flap needs to stick to your neopharynx, and if there is any potential space in between, it might collect and it may also, predispose to the development of a pharyngoepithelial fistula. So more than oral cavity, if in a total laryngectomy the drains don't hold, I'm more worried.
So sir was making a very valid point. Smriti ma'am, so he told about taking this peristomal stitch. We'll have to. So what would be your ideal distance between the two sutures when you're maturing the stoma? So would you take it more close, or would you take it wide enough that it would breathe well, or would you keep it in between?
We should not be taking too many sutures, and the closure should not be very tight. So we take the half mattress suture when finalizing the stoma, and of course you need to ensure that the stoma is not communicating with the neck wound. And not just in the case of total laryngectomy, but whenever you are doing a elective tracheostomy, so even in those cases, sometimes the stoma site tends to communicate with the drain, and that can also result in the drain not functioning.
Okay. Sir, is there if the drains are not holding? So one of the residents says you put it onto continuous suction. So yes, sir, it's 12:30 in the morning only. So probably it's 12:35 now. So sir, now so the resident asks you, sir, can I connect it to the continuous suction on the continuous or wall suction? So what's your take on it, Vishal sir?
Just to add to the previous point on drains, and the general philosophy is if you're based on the number of compartments you open, you keep the number of drains. So if you only open like in SOHD anterior compartment, keep one drain under the muscle, and if you've opened the posterior compartment, also keep 2 drains, so that each compartment has a drainage. The other part you said was about not holding and keeping it to a continuous suction. So I think before attempting that, you need to first find out the source. Without that, I would say it is unwise to simply connect it to a continuous source without understanding what could be the reason for the leak that is persisting. So is it an intraoral communication, or in these cases of laryngectomy, is it a stitch that is there? So those are things that you would want to consider before you directly put a continuous thing, because this is going to, and the pressures also of what pressure you're going to use to put that continuous thing is also going to matter a lot.
Right. So next, so we'll go to the next scenario. So in a patient where we have done a bite resection and a PMMC, so now the drains are not holding. Would you change anything? KK sir.
Again, not holding, right?
Not holding. We are still not holding. It's 12:45.
One reason maybe we have done an inferior alveolectomy, maybe connected to the nasal cavity and sinuses. Again, the compartment is not fully closed up, so that could be one reason in bite resection.
Yeah. So basically, this was to iterate that. So drain not holding means we should understand where the problem is existing, and we should understand that holding of drain is very important when it is a case of total laryngectomy. As sir was mentioning, we need to understand the reason why we have put a closed suction drain. So it is to drain the compartment. So so in bite resection, so because the cavity may be exposed to place where there is air, so that is the reason why the closed suction drain is not working. Sir, you want to add something?
Yeah, and as Vishal and KK both mentioned, if that drain is going into that area which is open, so when you're placing it, see to it that the end of your suction, end of the drain is rotated towards the lateral half of the neck. So if it doesn't migrate. So most common problem is when our drains migrate and they enter and open into a cavity. So in the tongue and floor mouth, it might be actually between the myloid and your posterior end, between the stylopharyngeus. You have just opened it. So now you're not sutured that area, and the drain has migrated there. If it's in the bite resection, it's going to migrate into the maxillary sinus. So if you rotate your drain and place that tip, which is going laterally, it'll never migrate.
Just wanted to add one point, sir, that I've seen it that in our residents typically when they raise the posterior flap, if they puncture it, that's where they put the drain.
They put the drain, exactly. So I was coming to that point also. So is it, why should it not be done? Would you be able to explain better? Like, if they, while raising the level 5 flap, they have made a rent there. And the natural tendency of resident is like they push the drain to it so that they don't have to jimmy it through the skin and then get it out. So would you recommend that? Like taking the drain out?
By the time they have done that, they would have not listened to my recommendation. I don't know. It's a very high level of escalation if they are going to call me for that.
No. Firstly, it's a burn. Okay. So it has to be excised.
Yes.
Once you excise it, then you better place it there and take a proper stitch.
Yes. Yeah. So this was because all levels of surgeons are listening to this. So I just wanted to start with the smallest one and then go with increasing levels of difficulty.
But I'm just curious to know, KK, when was the last time you fixed a drain?
So you are seniors, sir. You guys are
No, this is out of curiosity.
No, even if I'm not stitching, I usually stand behind them and tell them. Usually what they do a mistake is usually they pierce the external jugular vein and severe bleeding and then get caught in. So yeah, we have to supervise.
So that piercing the external jugular vein is even more troublesome when you've raised a local flap, which is a submental flap, which the vein is draining to the EJV.
With a lot of care and with a lot of love and care.
That common facial vein is draining to the EJV and you're taking the drain out through the EJV and then that's a problem. Now what do you do with the flap?
Then you call your plastic surgeon, now come and reconstruct.
So
and
that's
all veins are fine.
Yes, so we just have to be careful, and that's the last thing that you do, maybe towards the end of the day or whatever it is. So everybody is tired, so we need to be careful at every time point. That's the other point.
So what is the ideal time to put the drain? Before microvascular anastomosis or after micro?
I think it's before. If you ask me,
before the plastic surgeon comes.
Yeah. So that they don't say anything. Is it?
No, so that they don't mind us putting the drains.
No, and also the placement of the drain is very important. So not only the drain should not be hitting against the anastomosis, but it should also be doing its job. It should do the job that it is meant to be there. Otherwise, you can as well not have the drain. So keeping the drain winding and hitting, going somewhere just to keep it away from the anastomosis probably doesn't serve the purpose of having the drain. So we need to balance both.
Since we are discussing so much about the drains, last 2 weeks back in Kerala there was a big news. So one of the surgeons in Trivandrum Medical College put a glove drain, and it was in the news. The patient gave a complaint that the surgeon has put a part of the gloves and sutured it and came. Okay, so the point is, which is better, the corrugated drain, the glove drain, JP drain, or Romovac drain?
Panel. So me, oh my god, sir, I think
after the court case, I think then avoid the glove drain.
Yeah, avoid the glove drain.
At least some wisdom there.
It is all in the news.
So, yeah. Closed circuit drain. So,
but Jackson Pratt drain, I think it's more expensive. It's a little better than the Romovac drain, but yeah.
Yeah, mainly because it is made of silicone and it is malleable.
And another thing is about the placement of the drain is that you need to leave a little mesentery.
Yeah.
Now people are misusing this. When you put a mesentery, you are allowing yourself a chance of declotting. Now please understand for the residents that please do not do the declotting by removing the whole drain out and then shoving it back in. It defeats the purpose of sterility. So you have to have proper sterile conditions, and only if you actually require to declot and it is not helping after declotting, that's when you remove a few holes out.
I think we used drains learning from Dr. Dev. He's the person who taught us how to put the drains. See, way back 25-30 years back, we always fix the drain at the distal end, not at the proximal end. And at the proximal end, the hole should be away from the puncture. And another thing, you have to go through the muscle, not just through the skin. If you go through the skin, there are always there is a possibility of ear leak. So if you go through the muscle, if muscle puncture becomes wider, better you take a vicryl suture to close that muscle widening also. This is how we are learned. Of course, drain placement is the most important. It is really revolutionized the healing of the head and neck wound. Imagine before drains, even a thyroidectomy, they are putting a sort of dressing. The drain placement is very, very important in head and neck procedures.
Get a better sleep also.
Yeah. So the next scenario is, so same. So, but now the patient has pulled out the drain. So it is POD 1. So how would you manage this case? Like, patient has pulled out the drain, you have done a tongue wide excision, neck dissection surgery. So would you go back and put the drain, or how would you manage the case? KK sir, patient has pulled out the drain.
There is no hematoma.
No hematoma. In this patient, no hematoma.
I don't think we need to worry too much about it.
Okay.
If a hematoma later develops or seroma later develops, you may have to handle it.
Yeah.
But I don't think we should be too much enthusiastic and try to put it back.
So would you change if this were to be a laryngectomy case? Krishnappa sir?
One thing I want to say, what we were using the cautery machines and all earlier, and what was the drain we used to see when 10-15 years back. It was, first post-operative, usually 150 ml, sometimes 200 ml was there. Now, the kind of cautery hemostasis we maintain. Post-operative, first day, even laryngectomy also, hardly we see less than 50 ml. So, I'm not that much worried about this, pulling out the drain, not working the night. Our residents, I know, I will take, okay, don't worry, keep it. See, within 3-4 days, we are removing the drains. Earlier, we used to keep 6-7 days, 10 days, we used to keep the drains. Nowadays, I am not very much worried about this drain, how much it is coming. Really, it is a lesson.
I think you need to look at the patient profile. If the patient is hypertensive, you've had a bloody field, patient was on some blood thinners, then you would be better off opening 1 or 2 stitches and giving a compression dressing. If the patient was otherwise young and having no problems, like KK said, there's no hematoma, I would observe. We need to also know that there are randomized studies that have looked at placement and no placement of drains after a neck dissection. So up to 100 cc, there is not known to have any complications. Of course, the resolution of that seroma takes a while, but it will not increase your complication rate. So I wouldn't get worried unless there are any comorbidities.
Professor Piazza, you want to add something?
Yeah, for me, the most important thing is to avoid that the patient remove the drainage in the first day. I always stress my resident to make a tobacco pouch surrounding the drain with a lot of knots. And honestly, never say never, but I don't remember a drain pulled out, because if they pull a lot, they remove the neck together. So it's very rare that they pull the drain in the first POD.
Right. So what we call as Roman sandal knot has to be at least 4 to 5, and that must have at least a small sub-millimetric kink into the drain, so that that is holding it very tight in place, so that the drain doesn't come out. So coming to scenario 2, so 70-year-old male, ECOG 0, good performance status, carcinoma of right piriform fossa, CT4A-N1. So the patient has undergone total laryngectomy, bilateral MND, primary closure, and primary TEP has been put up. So the on-call anesthetist will call you. So let us keep it as 10 p.m. So we have stopped getting up at 12 now. So on-call anesthetist will tell you that patient is having saturation of 94% with 8 liter O2. So he was worried that there could be some pulmonary embolism, so he got a chest X-ray done. So this chest X-ray is not of patient. Don't tell me that there are no leads there and this is not taken bedside. So this is a representative case of the patient. So chest X-ray was done. So the anesthetist tells that the left dome of diaphragm is elevated. So he was wondering whether it was pleural effusion. So he got a USG thorax done. So there was no pleural effusion. And he tried to see the diaphragmatic movement on the left side. So there was no diaphragmatic movement. So what are your comments? Vishal sir.
Sorry, this is a total laryngectomy.
Bilateral MND. Primary closure plus TP.
Which side?
Sir, this is on the left side, left PFS. Okay, let me add one more clue. Neck dissection was done by a resident.
Okay.
Yes. So neck dissection was done by a resident. Yeah.
I think other than, I think the main thing is to look at then a phrenic palsy to
Yeah.
be one
Right.
area.
Yeah. So yes, it is. So the patient has left unilateral phrenic nerve palsy. So in this unilateral phrenic nerve palsy, so I'm just highlighting the points which were not touched upon today because these are very important points to understand. So when they are doing level 3 and 4 dissection, so they should understand where the phrenic nerve comes and then how to handle that. Shiva sir, you have any pointers like where the phrenic nerve palsy would happen and then how would you deal with it?
So usually when we are dissecting at level 4 and when there's a kite leak and you are trying to manage the kite leak with some overrunning sutures, that is one. And also when your it has happened with me once when the assistant is overzealously retracting the soft tissue. He or she tries to put the finger beyond the vessels and tries to retract even the level 4 soft tissue. It sort of exposes the phrenic nerve. And also we should remember that when you're working in that level 4 area, we should never go below the prevertebral fascia. You should always be above the prevertebral fascia, above the transverse cervical vessels. And if you do manage to damage the phrenic nerve intraoperatively and you identify it, we have to try to repair it if that is possible. But if it goes unnoticed and you look at it in the post-op, I think unilateral phrenic nerve palsy many times may go unnoticed. The patient may not have any problems. But if the patient has any pre-existing pulmonary issues like COPD, bronchial asthma or anything of that sort, then it becomes a problem that the patient's saturation may not be maintained. Even recently it happened with us. The patient had, the saturation was always, pre-operatively he was fine, but post-operatively the patient's saturation was always hovering around 90, 92. And everybody was worried. And with oxygen, then the saturation went beyond 95. So when the chest X-ray was taken, that was the kind of picture that was there. So then we realized that the patient is not able to maintain the saturation because of this particular issue. So unilateral phrenic nerve palsy may go unnoticed provided if the patient doesn't have any underlying pulmonary issues, but it may be a problem in some patients and especially in those with underlying problems. Bilateral phrenic nerve palsy is a major problem. The patient may end up with a tracheostomy.
So 8 liters is unlikely in this patient.
Yeah, I just put it as
So this patient, if it required 8 liters, I would look at any restrictive lung pathology. So this patient might really require some other medications.
Right.
And as Shiva said rightly, would have gone unnoticed.
Yeah.
And the other part, Karthik, is that most of this will happen in an N plus neck.
Correct.
In an N0 neck, generally with a limited SOHD, unlikely that you would go that far to hit a phrenic nerve.
Right.
So that is why I even saw the first case wherein it was written CA tongue selective neck dissection 1 to 4.
Yeah.
Now I've seen this answer of selective neck dissection 1 to 4 for every CA tongue patient and I asked them why and they quote the Bayer's paper. And that is where the problem is. So if it is N0 neck, even if it is tongue, you can stop at 1 to 3. Now everybody say there's no morbidity, we can as well do 4 safely. Now, this is one of the morbidities which will end up if we unnecessarily do a level 4 when it is actually not indicated and it's being done for various extended indications.
Not to pull the soft tissue below the omohyoid. You have to stop and round off at the omohyoid.
Yes. Sir, also overzealous use of cautery whenever they enter the prevertebral tissue. and when they go near the muscle, it tends to bleed there. And then at level 4, when they mistake the bleeding from the ascending branch of transverse cervical artery, so they may presume that it is coming from the posterior aspect, and then they may have the overzealous use of cautery over there. So there is one excellent paper by the Brazilian group where they have looked at the incidence of unilateral and bilateral bilateral phrenic nerve palsy following neck dissection. So in their setting, they came up with around 7 to 12% was the range, and none of them had any symptoms. They came to know only when it was bilateral phrenic nerve palsy. So as Sir mentioned, that we need to understand what the underlying cause is, and we need to triage the patient and manage accordingly. Dr. Piazza, do you have anything to add on to this?
My personal experience, I've never seen a phrenic palsy for desaturation in the first POD. Frequently, the diagnosis is made by chance because the patient becomes come to have a fever, postoperative day 3 or 4, and you make a chest ray and you see the elevation of the diaphragm, a pleural basal effusion, and then you know that there is the phrenic nerve palsy, some kind of basal pneumonia, and you give the antibiotic to solve the problem. Yeah, and all the other things you mentioned are perfectly in line with my experience.
Yeah. So as we are running short of time, so I've been told to take 2 more cases if the panel is okay. So one more very common scenario which we encounter routinely. So this is a 56-year-old lady who has undergone left composite bite resection for left buccal mucosa with SND 1 to 4 followed by a free ALT flap. So following that, persistently patient is having high drain output, more than 300 ml per day. So the color is serous. So even on post-operative day 9, it is serous, and we suspect there is a parotid fistula and there is a salivary leak into the neck. And day 9 post-operative histopathology comes, it is PT2N0. So how would you manage this situation? Krishnappa sir, do you have any points? If we are not giving RT to this patient, there are no adverse features.
Usually, in this case, salivary leak we can manage with the glycopyrrolate tablets, something like that.
Patient is on glyco OD, patient is having tachycardia also, and patient is having, the maximum permissible dose of glyco is being given. Despite of that, patient is having 300 ml output per day, and patient is a bit hefty. So any other management, sir, you want to add anything, sir?
So you got tachycardia because of the glycopyrrolate.
Glycopyrrolate. So
only
the maximum,
1 tablet?
No sir, 2 tablets. The maximal permissible dose has been given, so it's around 110. So it's not because of any other cause. So otherwise, patient is okay.
So one option you would have to explore is to understand where it is coming from. Can you isolate it?
Yeah.
So if you can do an ultrasound and identify where is that loculation, and whether you can you can explain to the patient that this is a loculation, I would need to explore and suture it.
Yeah.
That is the only option I feel that is valid, because if day 9 and it's still 300, I don't see any reason if the patient is having other comorbidities that they cannot give glycopyrrolate.
Yeah. Sir.
No, I would agree with sir. I think 300 ml is very high.
Yeah.
And you can't be waiting after that to wait, because you are going to bathe that area with the carotid sheath, and all of that is going to be exposed to more of these inflammation, infections, or even eventually form. So I think you should explore it at the earliest and not wait.
Right.
First of all, we have to prevent it.
Exactly.
In a bite resection or a buccal mucosa resection, they spend some time while we are raising the flap and when we are in the anterior border of the masseter to identify the parotid duct and clamp it in all cases. Sometimes there may be accessory ducts. Even if you clamp the major duct, look for any smaller ones and clamp that too. That's the main thing. And if it is a minor leak, and sometimes you may be able to drain it into the mouth, especially if that patient is going for an RT, it may get settled with an intraoral drainage. But if it is such a large output, you may have to get in and take the patient in and find the leak and close it.
We have come across this type of problem, especially in the post-operative scenario. when you do a bite dissection with a vascular flap, I have come across 4 or 5 times, 9th, 10th, 12th day developing a big swelling, a cystic swelling, and aspiration is yielding a serious saline leak. But I have not done any much surgical intervention. I just put a pressure band-aid. And of course, once in 2-3 days I used to try. And of course, this patient you are in need of post-op radiotherapy. And discussed with the radiation oncologist. Giving radiotherapy within a week or 2-3 days, it has sealed up and it has healed. This has happened 3-4 times.
May I add?
Yes, ma'am, please.
So we have quite a bit of experience on using intraglandular botulinum toxin. If this is a parotid fistula with no orocervical communication, so you can use the ultrasound and stay above the retromandibular vein, and for the parotid we prefer to inject around at least 50 mouse units of botulinum toxin at multiple areas, and the effect usually comes around 48 to 72 hours. You will see a drastic reduction in the drain, but you can see the effect continue to almost 2 to 3 months. So it's not a permanent solution. You might have to repeat the injection botulinum toxin.
So you said it shouldn't be communicated something.
Yeah. So basically, we have seen in salivary parotid fistula, and also seen in the separate cohort of patients with orocutaneous and pharyngocutaneous fistula as well. But in those, it is to basically reduce the time taken for the fistula to heal. It doesn't respond as dramatically as seen in the case of parotid fistulas.
There's one point for the residents. See, whenever we do a neck dissection, the tail of the parotid is removed.
Yeah, I was coming to that. No, please answer.
No, so the tail of the parotid being removed itself keeps that area very vulnerable for this kind of a thing, and which is why we take a stitch of the tail of the parotid in that region to secure and prevent such leaks, and that's very crucial as a step to complete the neck dissection at closure time.
Right.
Oftentimes, if at all we're missing it, that should be a part of the checklist for residents.
Right.
And lastly, when you're raising the flap, when you're doing a bialveolar composite resection, when you raise your flap, people tend to go above below the subplatysmal elevation goes above the parotid. So you're creating a dead space above the parotid. You are at risk to damage the parotid. You need to stay below the masseter. So there'll be some amount of masseter which is a sliver left on the gland, which will protect the gland and the nerve. So many times I find that the upper branches are also damaged during a bilayer composite because you've really gone and elevated that flap, and now you're raising it between the flap and the parotid. So the nerve is also at risk. So take care that when you raise this flap, you should be trying to be below the masseter unless you have to remove the whole masseter, which is not required in all cases.
Yes.
Just one last point is that when there is a collection, like what Nanjana Prasad was saying, I think we should be careful when we're doing the repeated aspirations, because when we have to do it with all aseptic precautions, otherwise we'll be we end up with an abscess. So that is another thing.
Yeah. Thank you, sir. Dr. Tiazo, do you have anything to add to that?
No, it's perfect. I mean, it's completely agree with all things done.
So I just want to ask one question about this. So when would you do a tail parotid excision? In what oral cancer would you do?
I think we have stopped doing that unnecessarily unless you have some nodal mass that is there abutting it, but you don't essentially have to take the tail parotid all the time, which was the classic description in the Kryle's neck dissection, but I don't think so. We have to do it in an N0 neck routinely.
Yeah.
There are two reasons you do that tail of the parotid. One is because there could be lymph nodes.
Yes.
Or there, as a part of the neck itself. But by retraction and exposure, if you can get it, you need not do it. But if you are obviously seeing a PET uptake or a thing that there is a tail of the parotid node and in an N+ neck, I'm saying then be cautious.
Right.
Another thing is in skin involvement in oral cancers.
Yeah.
Wherein there is a high likelihood of this involvement.
9 to 11%. So would you be doing it in that setting?
I would.
Yeah.
If there's a fungating node with skin involvement over there in that region, then the draining basin is the parotid node.
Would you do a superficial parotid or would you do a superficial?
I think the tail of the parotid,
Yes, sir.
there are two reasons that we are partly cutting the tail of the parotid. One, to expose the digastric muscle. To expose the digastric muscle, part of the tail of the parotid, we have to either retract or you have to cut. Of course, in addition, for inferior parotid, infraauricular parotid lymph nodes to be removed. This is a classical trials advice. But even in M0 neck, it's better to cut the tail of the parotid to expose a good length of the posterior belly of digastric, so that you can clear the lymph nodes in the posterior triangle level 1B, level 2B and level 2A. So unless a good exposure and cut the parotid, you don't get an exposure that easily, especially in a lymph node, in a buccal mucous membrane or a tongue, you have to clear all the nodes.
This is one quite interesting one which we recently encountered. One of my colleagues had called to us. So actually, this is a no. Yes, so that was the over enthusiastic surgeon. Let me not. So it was on. So they performed a surgery, the total laryngectomy, bilateral neck, primary closure with a TEP. Sorry, I forgot to add. Total primary TEP was put for this patient. So it was a CA glottis. It's taking very slow. So post-operative course was uneventful. So post-operative day 8, he decides to start the patient to. He asked the patient to speak with TEP inside. So on day 9, he said, and he went to rounds, and then he saw the nasogastric feeds are coming from the train on POD 9. So what could be the reason, sir?
Can I start with that?
Yeah, please, sir.
Well, I think that starting producing voice at 8 days after surgery is too early, and is perhaps the reason why there was a fistula formation in the neopharynx. In my home, even the best case scenario doesn't drink anything up to 10 days after surgery. And I know that saliva goes down by the suture line from the very first minute after total laryngectomy, but I do not allow never to drink anything before the 10th day after surgery. And obviously, I cannot allow the patient to try to speak before, I would say, 2-3 weeks after surgery, because the phonation and the pressure that they have to put into the neopharynx is definitely higher than the pressure and the risk of fistula while drinking and eating. So they first drink, then eat, then speak.
Yeah. So anybody has any other comments? So basically, when we create a neopharynx, for residents to understand, so when we create a neopharynx, it will be a hollow tube, and when we put a TEP, so there is a communication from outside, and the valve will let the air to go from outside to inside and nothing inside to out. So when you ask patient to vocalize before the neopharynx is mature, it will bellow. It will bellow. And because of that bellowing and because of the intraluminal pressure in the neopharynx, the sutures might have given way. So that could be the possible reason why this patient is having NGT feeds coming out through the knee. So do you have any pointers towards managing this issue, sir?
As mentioned, I think our first priority for post-total laryngectomy is to make sure that the patient is able to swallow safely and make sure that there's no leak. And there's no hurry to start the oral feeds and make the patient phonate at the same time. So as what Dr. Pierre just said, we can start phonation after 2 weeks minimum, not before that. Before that, the priority is to see to that the patient doesn't have a leak and swallow the leak. And if the patient does develop a leak like this, I think we have to tell the enthusiastic surgeon to hold on to the speech and give this probably now can be managed conservatively, depends on how amount of leak and the various principles that we just discussed. Manage the leak and proceed accordingly.
Karthik, another another point I would say is one aspect is speech, the other aspect is partially blocked NG tubes. When you over pressurize
Yes.
and put,
Yeah.
you can have a lot of regurgitation,
Regurgitation.
which could lead
Yeah.
to this kind of a scenario. So one is pushing the tube in, ensuring it's not blocked is also important, because because oftentimes you see an NG tube gets very blocked very quickly based on who has taught them on how to feed the NG tube, on straining it and other things. So that part could also be emphasized, and phonation part. But I think also NG tube could be playing a culprit in this, and we have to teach that NG tube feeding itself is a good topic for residents to know, so that they should also be able to teach the patient's relatives on NG feeding.
And the other thing is how, as what was mentioned, NG tube feeding. So we should feed on a continuous bag rather than feed 500 ml or larger quantity at same time. And the other thing the patient's attenders do is that after feeding, make the patient lie down. And when they do that, the patient tend to vomit. And in such a situation, if the patient vomits, then it's going to be havoc. It's going to just come into the wound and into the stoma and all of that. So we have to tell them that the feed has to be continuous in small quantity rather than at one point in time. And after feeds, the patient has to be made to sit upright for some time before making them lie down, and give some anti-emetics or prokinetics and all these, and proton pump inhibitors. So all these are part of management of a pharyngovenous fistula.
In this situation, will you take out the drain or continue the drain?
If the drain is there,
usually we do not keep the drain for 9 days. So usually all the skin will be stuck and it will be almost disclosed. Even if it is there is something dehiscence in the pharynx also, it won't come in the. And second one, this enthusiastic surgery. Second one is the stoma is still not at healed. The patient cannot put a finger and close this one and he can start vomiting. So these are practical.
I think once a leak starts and anything foreign there is a source of infection. So, and if the drain is not going to help in any way other than telling you how much the output is. So I think we have to take a call as to, if the output is not too much, rather open the wound, take the drain out, and whatever is coming out, let it come out through the wound, and just keep doing the dressing and compression bandage.
NG feeds in the neck is a bad news.
Yeah, it's a bad news.
I think that's the point, that all your efforts towards healing of that wound is going to go for a toss in the next couple of weeks. So we have to, I would in fact go one step ahead to say no harm in exploring it, giving a wash, clean up that entire area and resuture it, because it's not worth the risk.
Right. I agree, because if you have a silent leak, it's more likely it has to be from one area. This is a propulsive leak. It could have opened up a few stitches, and there is again contamination of the wound. So if a patient has been coughing all through and has a leak, my threshold to explore would be low. So in this case, I would explore, I would give a wound wash, and I would take the stitches around it, usually at the base.
And more so if it is in a salvage setting.
Yeah.
Also
Dr. Piazza, do you have any comments? Would you explore the patient, or would you manage the patient conservatively?
Well, my experience with late fistulas like this, or massive fistula with fits going into the neck, is that they very rarely heal as conservatively. I can make a trial for 3-4 days, but usually at the end of the story I reopen again the neck and usually do a free flap for closure, because with the salivary stent inside, even though the mucosa is enough, after this kind of broken up, perhaps I fear that there is a problem of vascularization. I cut a part of the mucosa, I put a radial forearm, for example, on ALT and the salivary stent, and then usually 10 days later the patient is okay.
Thank you, sir. So we have, can we take one last question, sir? To the panel. So when total laryngectomy, they have not used Glutzoensin incision here. So they have taken 2 separate incisions, one for horizontal incision and D-shaped incision for the stomal maturation. Unfortunately, the over-enthusiastic surgeon did not know that the size that needs to be taken. more than two.
See you over.
No, it's okay. Hypothetical.
See somewhere around.
Yeah, it's okay. Yeah. So the distance between the incision taken was less than 1 centimeter, and POD 2-3. Now the skin bridge is black, and now there is a leak through that site. So how would you manage this? Hypothetical scenarios.
No, I think, but the point is, if the skin is black, means it's gangrene set in there.
Yes.
Correct?
Yeah.
Quick debridement, and that area needs to be again replaced with something.
Right.
Obviously.
Right.
To prevent any further deterioration of the condition, of worsening, evolving it into a fistula, or because the worst thing that you can have is a pharyngocutaneous fistula open directly with such a large defect. That's the worst thing you can have. So I would have put a reverse PMMC or something, or a free flap or something, but you need a lot of muscle buttress to cover and protect the pharyngeal region, the neopharynx, and also protect the skin area and give a cover.
Sir,
one point I want to say, we never use flexor incision anymore. It's always a transverse neck crease incision, and if it is a salvage neck dissection, it's always a separate incision from the tracheostomy, around 3 centimeters above the stoma.
Yeah.
The skin flap necrosis, it's a difficult problem. Sometimes we can manage it conservatively. If there is a the PMMC or something inside, we can manage it conservatively. But make sure if there is a leak, it will be directly draining into the tracheostoma. Then you need to put the cuffed tracheostomy tube and some gauze pieces around it, so that the secretions are not going in, and manage it conservatively.
Right. Thank you, sir. Dr. Piazza, do you have anything to add to this?
Well, personally, I don't like to make a separate incision for total laryngectomy. This is my only point of view. So I do a classic apron flap passing through the stoma, and in this way I usually prevent these problems. But that's my point of view only. I don't want to stress it too much.
Okay, thank you. I think Dr. Radhika will not let me answer. So how would you manage this skin bridge flap? Right, so you would want to put replace it. So any particular flap you want to put in? You use mic once.
I think sir told spiral PMMC. I would go with that only.
Yeah.
Yeah.
But why this patient has developed fistula? You said
Sir, I meant two situations there. Actually, I just wanted to present one case. One is without leak and one with leak. Hypothetical situation. Because this being only one case, so I've taken this. Okay. So thank you very much for the expert panel for discussing. It was my pleasure to enthusiastic plan.
I had a comment to make.
Yeah.
We had the exact same problem with the leak. I showed the picture.
Yes, sir.
Yeah. That patient also had a leak. So we did what Vishal said.
Okay.
Now we got
sir.
It was an over-enthusiastic resident who had retracted the skin panel.
Right. Thank you very much, sir, for your wonderful. Thank you.